I'm Helen, and I run, for those of you who don't know, I run the Community Champion program on the Edward Woods estate. We're very happy to have with us today Dr. Chad Hockey, who's a GP from White City, who some of you know well, who's going to answer questions, questions that have been sent in beforehand, and questions from you today live to him. We had over 50 questions which were sent to us from all kinds of people before this meeting. And not everyone who sent questions in can be here today. So we sent a list of them off to Dr. Chad, and he's going to answer some of those in his talk first. So the idea is that he will talk for about 10-15 minutes, covering some of those points that perhaps you sent in yourselves. And then we will open the meeting out for a discussion, for you to ask questions and for a discussion. We've got until about 12 o'clock. So, and I'm just going to hand over to Nieves, who's running the technical side of things. We are going to record this session because if that's okay, because a lot of people who did want to come today can't, and were very sad about that. And I said, well, if we can record it, then that means we can put it online for people to have a look at in their own time. Nieves, do you want to say a bit about what we're doing in terms of muting and people asking questions or whatever?
Of course. In case someone doesn't know me, I'm Nieves. I'm the project administrator for Addison Champion, and I will be hosting the session today. So I know there is a lot of interest on this subject, and many people cannot attend, as she said, so we will be recording, but please feel free to turn your camera off so you won't appear in the recording. And we will try to keep our microphones mute, so I will mute everyone except of the doctor, of course. And please, if you want to say something, try to do it by the chat. If you don't know how to use the chat, you can use the reactions that you have down. And just thank you very much all for joining today. If you have you feel something interesting, just spread the word when the session finishes. And if you have something to tell me about the session, yes, please talk to me after. And it's always good to have a feedback from everyone. And now we hand over to Dr. Chad to kick us off.
Off, not kick us off.
Yeah. Brilliant.
And
thank you.
let me find Dr. Chad in here.
Thanks, Nieves, for that.
Great. Well, thank you so much for inviting me to come to a meeting this morning. There's some familiar faces, some people I don't know, but no, it's a real pleasure to be able to join you. So thank you very much indeed. As Helen was saying, I thought rather than going through all the questions one by one, the better thing to do would just be to talk for 10 minutes or so, and hopefully I can address some of the questions just by having a sort of brief introduction, and then pick up from you the questions that I haven't answered, or particular points that you want to cover. I should say as well, I'm very happy to join subsequent meetings if there are people that can't be here today and want to come a different time. You're more than happy to join another time. So as you heard, my name's Chad, so Dr. Hockey. So I work in a practice in White City, GP practice, and I've been involved with the vaccination campaign that we've got in White City. So as I'm sure you know, GP practices are arranged into groups, and those groups are called PCNs, and the 9 practices in North Hammersmith and Fulham are part of one PCN. And so we chose to try and do our vaccination campaign from a community setting, and Mary, I think, is on the call, kindly agreed to accommodate us at the community centre. So we've been doing our vaccinations from White City Community Centre, and we started our campaign in the start of January, or probably the first or second week of January, and are still vaccinating from the centre now. During the course of the past month, I think we've done about 4,500 people from White City. We've vaccinated about 4,500 people, and there's been a lot of common questions. The ones that you sent through are the kind of questions that we've had from people that have come through on the day. A lot of it has been around choice. I think people have been worried around, should they have the Pfizer vaccine? Should they have the AstraZeneca vaccine? A lot of it has been around safety. So how do people know that they can trust the vaccine? But to be honest, most of it has been around trust. So the way that the campaign has been done, the way that communities have been affected, or the problems within communities have, within society have been amplified by COVID. All of that has come through from within the vaccination campaign. So if I sort of pick up on some of those bits just to kick off with, so the vaccine safety, yeah, it's been a problem right from the start. Concerns about the vaccine safety and it's having been developed so quickly. What I'd say actually is that this has been a huge effort from the scientific community, going back for many months, and one of the reasons why it's happened so quickly, so normally you wouldn't get a vaccine developed in this kind of time frame, is because of all of that collaboration that's happened. So in the same way that you've seen communities work at speed and all the change has been accelerated, the same thing has happened scientifically. But that's not to say that there's any less attention been paid to developing the vaccine in a safe way. So they've still gone through the same rigorous kind of steps scientifically, doing the same kind of process with studies. They've just accelerated the way they've done that. So in order to get through to be the regulation, they've got to go through the same sort of process, whether it takes a year or 5 years. So it having been brought to the market and put in place more quickly, I wouldn't worry from the safety side of things. The same kind of process has happened. The other thing is people have worried about, okay, well, this has just been, it didn't come through in your questions actually, but one of the things I've heard is how come it's come through in England? Why is there a difference internationally? Well, actually, these vaccines have now they've gone through the same safety checks in multiple countries. And so from a safety perspective, there's absolutely no question at all that the vaccines are safe. There was concern initially around allergies, and I can see that's come through with some of your questions. So the vaccines don't contain antibiotics. They're completely, if you're allergic to an antibiotic or peanuts, or you have other allergies, serious allergies, that doesn't mean that you can't have the vaccine at all. With the Pfizer vaccine, there was initially some worry around anaphylaxis, so very severe allergies, but right at the start of January, they changed the guidelines based upon evidence and said, look, don't worry about it. And certainly from my experience at the vaccine hub, we've had people that have had a history of very bad allergies, needing to have adrenaline, and we've just kept a closer eye on them. They've had the vaccine and they've been absolutely fine. So having an allergy or being on medicines shouldn't stop you from having the vaccine at all. There's some questions about travel and sort of the more sort of social aspects. So people are saying, well, if we can't change what we do, we still have to distance, we still have to wear masks. Why have the vaccine? These vaccines were designed to prevent people becoming seriously unwell. So the idea of this is that we're targeting the people at most risk of being exposed, and at most risk of having an adverse, serious complication, like being admitted, ending up on ITU if they get exposed. So it's a twofold campaign, and the purpose of that isn't to get herd immunity. The purpose of that is actually to prevent people getting admitted and becoming really sick. So it's not a case of, we need to vaccinate 80% of the population. Not at this stage. This initial part of the campaign is protecting people from getting really unwell, and that's the reason why they've done these categories to cohort people, so over 80s, over 75s, and so forth. Other question themes. So there's some stuff here around the second dose This was really confusing. So they, when the vaccines first got rolled out, it was in the second week of December. So December the 15th, I think. And at that time, it was just the Pfizer vaccine that was the only one that was available. And they were saying that the second dose had to be in 3-4 weeks. And they subsequently changed it. And that decision was based on public health thinking. So the idea then was we can vaccinate lots of people with 1 dose or a small number of people with 2 doses. And so they looked at the evidence and said, there is probably some protection from 1 dose. There's probably enough protection from 1 dose to justify extending the time frame. It's been controversial. So there's parts of the medical community that haven't agreed with that decision to extend the dosing interval. But nevertheless, it was based on a public health reasoning. And so far as people can see, there is evidence actually that after 1 dose you do get a degree of protection. But the government have been unequivocal that actually the second doses are going to come through sort of 10 to 12 weeks. Are there going to be supplies? This is an unknown actually. The campaign is being rolled out at PCN level, which is the kind of hub we've got. They've also got these mass vaccination hubs, which have been set up. So there's one in Wembley, and they're also doing it through pharmacies. And so they've created multiple routes for vaccination. And my suspicion is that probably they're going to have to roll, I don't know this, but they're probably going to have to concentrate supplies to a more limited number of hubs rather than going to all of the hubs all at the same time. Going forwards, I would expect there to be supplies for people to have second doses, and I would expect there to be supplies for people to have first doses that haven't wanted to do that first dose in the first round of vaccinations. People have also asked about a third jab and the variants. Again, this is an unknown. So they're doing studies at the moment around are the vaccines going to be effective, for example, against the South Africa variant, but it's still unknown. And it might well be that come August or September, we're all going to have a booster jab. In the same way that with flu jabs, we have to have a booster every year. But this stuff is all unknown at the moment. But I wouldn't base, if you're worried about having your first dose on whether you're going to need to have a third dose, I wouldn't base it on that worry. I would concentrate on making the decision based on risk and benefit about the first dose, rather than whether there's going to be a supply in 12 weeks or 8 months' time. So I'll probably stop there, and then those were some of the common themes I think have come through on the questions that we've had at the hub, and then leave it with you to ask me whatever it is that you need to ask. So any questions, points, comments?
Hi, Dr. Chad. Hi.
Hello.
Henry, hi. I'm wondering, is it true that we're the only country that are having that 12-week gap between the first and the second jab? Because I find that quite concerning. Yeah,
you're not the only one that's worried about that. So there's a lot of anxiety about the 12-week thing. Internationally, all countries are looking at this with a slightly different lens. So there are some countries that so basically when they created the vaccine, so the Pfizer one particularly, they didn't do studies to look at the interval beyond about a month. So the drug company, so Pfizer and biotech, they're not going to stick their neck on the line and say it's totally fine to leave it that long. However, what did seem to come through was that about a week after the second dose, they were claiming 90-95% protection. And the scientists are arguing that that's too soon after a second dose for that to be due to the second dose. So they're saying actually that probably was the first dose giving that protection as opposed to the second dose. And so there's an awful lot of debate going on internationally around whether or not actually the Pfizer vaccine, for example, should be at 1 month or 12 weeks. Some countries are kind of going in the middle and they're saying 6 weeks. Other countries haven't really made a judgment call on it yet. The AstraZeneca vaccine is slightly different. They did do some reviews on that, at a longer time frame. So there is some evidence from the studies to suggest that actually a longer interval is absolutely fine. But the Pfizer one, they just haven't done the studies to be able to make that commitment scientifically.
Okay, thank you. And so, I mean, the 12-week wait for the second jab doesn't impinge on the first jab. It's just maybe there isn't as much protection as if you had the second one within a certain time frame.
Yeah, exactly. So the question here is, it's not so much around whether it's worth having the first one, because the first one will definitely give you protection. The issue here is whether you'll get enough protection from the first one to last you the whole 12 weeks or not. So whether 12 weeks is the right timing for the second dose. That's for the Pfizer one particularly, just because they didn't do the studies around it, and so they're basing this on, the scientists in Britain are basing it on the assumption that, like I said, they're claiming 95% cover after 2 doses that were given a month apart, and they were saying actually, if you look at the data on it, you wouldn't get that cover just from the second dose because it's too soon to have produced that antibody response. So they're saying actually it's the first dose which is giving you that amount of protection. But it's not been, it's not been based on studies, looking at people that are given a dose day 1 and then after week 12, which is the way that the scientists generally make conclusions.
So are you saying, Chad, is it based on assumption?
So it's based upon scientific reasoning, understanding of immunology and interpretation of the data. So it's all those things together, as opposed to the way that they often make decisions around vaccines, which is you'll do a study and you'll say, oh, we'll give a proportion of people their second dose at 1 month, a proportion of people at 2 months, a proportion of people at 3 months, and then we'll look at the evidence and collect the data around all those intervals. That's not what they've done. What they've done is the Pfizer, when they made the vaccine, they looked at the evidence after a month, and they found 95% immunity after a second dose. But then immunologically, they're arguing it wouldn't make sense for that to have been due to the second dose.
Right.
Okay, Anne-Marie.
Yeah, that's great. Thank you. Yeah.
Okay, there's a couple of questions on chat here. Because I've been reading them, I don't know if you answered this question, but I'm going to say now. There's one here which says, could it happen that the second dose is from a different vaccine?
Yeah, this is a big one, isn't it? As it stands, the second dose is the same as the first one, and that's the guidance we're currently operating under. So if you had AstraZeneca first time round, it's AstraZeneca second time round, and the same with Pfizer. However, there's studies underway at the moment to look and see whether actually that has to be the case. The issues around the vaccine are more around delivery, actually. So Pfizer, Mary will know this, Pfizer is a flurry of activity. We get 3.5 days from when it's delivered. We get 3.5. It's a 3.5 day shelf life. So they store it at -70. They take it out of this deep freezer and then they stick it in a van and then send it to us. And then from the minute it comes out of the deep freezer, we've got 3.5 days to use it all up. And so it's incredibly intense. You got 1,200 doses in order to deliver in that time frame. Whereas AstraZeneca, we can leave it in the fridge for 6 months. And so quite clearly, if we could give a second dose of AstraZeneca, it would give loads more flexibility in terms of what we could do, where we run the clinics. It just sits in a normal fridge. We haven't got to have all those cold chain worries. And so they're doing studies at the moment to explore whether actually we can give a second dose with AstraZeneca for people that have had Pfizer. But it's not known. So at the moment, as it stands, your second dose is the same as the first one.
Okay, thanks. Right, and then Patricia said, what are the different symptoms and illness and effects on the kind of illness you get from the South African virus compared to the original COVID-19 virus?
Okay, yeah. So from the virus itself, so viruses will produce the same set of symptoms. So so a COVID variant from South Africa or from Kent or from wherever will produce the same set of symptoms. It's not that it's going to infect a different organ system. It will still be respiratory in terms of what it will do. The differences between them comes into how transmissible they are, and to some extent the severity of the illness. And so anecdotally, so I didn't say, but I work in, as well as being a GP, I'm also a nurse. So I'm dual trained and in work in both roles, and I work in A&E. And my experience of, I've been working in A&E throughout the entirety of the pandemic, and my experience of this new variant that we've had, so the Kent variant, is that it's a different beast. I've seen people coming in that are much younger, and they seem much sicker. And so that's the difference between the variants. It's the transmissibility, so how many people will get it and how sick they'll get when they get it, as opposed to it giving different sets of symptoms.
Patricia, does that answer your question? If you like to unmute.
So they'll still get fevers and cough and so forth, the same set of symptoms.
Yeah, but as you know, is it a worse? What I'm trying to say, is it a worse?
Is it worse than
Is it worse? Yeah. So scientifically, that's not known. And I like I say, there's as it stands, there's less than 200 cases in Britain, and so that's not really clear. I would say that the variant that emerged in December in Kent definitely seems to be more it is more transmissible, and it seems like people get sicker. But the South African one, I'm not clear as to whether that is the same in terms of increased transmissibility.
But what's happening in South Africa with it then? Is it
I don't know.
In South Africa?
Yeah. So in terms of what's happening, so you've got to think as well about the how unwell people get, and the figures that you'll get will be dependent on the health service of that country as well. So, for example, death rates will reflect not just how severe a virus is, or how transmissible or how sick people get. It reflects people's access to healthcare and the level of care that people will receive. So it's not as straightforward as simply being able to look at a death rate in the country, but I don't know the statistics in South Africa from the top of my head.
Okay. All right, thank you.
Is that okay, Patricia?
Yeah, that's great. Thank you.
Thank you. Okay. Now I've got one from I'm going to hold your question, T, at the moment, because I want to ask Claire's one, which says, does the vaccine, because it follows on, I think, does the vaccine cover the various mutations?
Yeah, so this is a really tricky one. So the short answer is that no one knows. When viruses mutate, they generally there's two ways that they can do it, and on the whole, they just kind of morph a little bit. And so the analogy I'd use is, if you imagine, how many people on this call? 21. Imagine if I got one of you to write something down in your own handwriting, you transcribe a paragraph of something, and then you passed it on to the next person and asked them to copy it down in their own handwriting. By the time it got around 21 people, some people would have read a word, and they'd have read someone's writing, they'd have changed an R to an S or an A to an E, and things would have been changed a little bit, but you probably would be able to read it still. It just, words would be different. It wouldn't look exactly the same. And that's more or less what happens with viruses when they mutate. So you can kind of recognize it's the same sort of thing, but actually, is it exactly the same? Not quite. And so the likelihood is when viruses mutate that way, that there's still some protection. But the only way that they're going to know is by doing studies, which they have, as it stands, haven't completely finished. They've got a few small scale studies, but the scientists look at the virus, the mutation, and they say, yeah, I can kind of read the paragraph here. It looks like it's more or less the same. I can make sense of what it's saying. This is probably going to be all right with the vaccine, and that's kind of where they've got to, but it hasn't been confirmed. What they can do is they can tweak the vaccines to where they think the mutations are going to be. And that's what happens with the flu jab every year. So every single year, the flu jab's different. It covers the mutations, and that's probably what's going to have to happen with COVID going forwards.
Claire, does that answer your questions? If you like to unmute. Anything else you want to ask? No. Yes.
Yes, thank you. Yes.
That's okay. That's clear.
Thank you.
Okay. Thanks, Chad.
Yeah.
Okay, so
The second way things mutate, I'm sorry to jump in, vaccines can mutate a different way, and that's where it's almost like, I don't know, someone's pressed Google Translate, and it just then turns into a different language. And so the paragraph, it's not just like you've changed an R to an S or whatever, it's just completely different. And when that happens, then vaccines won't cover. But that hasn't happened with what we've done so far.
Okay, now I've got a question from T. It says, what age group are we up to in Hammersmith and Fulham in priority groups?
Okay, so we've got very different demographies in different parts of Hammersmith and Fulham. As you all know, North Hammersmith and Fulham is predominantly minority ethnicity. It's a younger population group. South Hammersmith and Fulham tends to have a greater proportion of people that are certainly over the age of 70 and definitely over the age of 80. And so that means that each geography has had different volumes of people to vaccinate. Within that, we've also had the scenario of different delivery schedules to each of the different areas. So we've all had the same instructions. We've got to follow these prioritization categories. So priority 1 is care home residents. Priority 2 is people over 80. Priority 3 is over 75. Priority 4 is people that are shielding and over 70. And the request was that we did as many as we could of priorities 1 to 4 for the first round. In fact, actually, they wanted us to do priorities 1 and 2 to start with. So we've got in North Hammersmith and Fulham about 1,500 people in categories 1 and 2, and we were given 5,000 vaccines, with 3 of those batches being Pfizer with a shelf life of 3.5 days. That's 3,500 doses, give or take, that had to be given in 3.5 days. So way more vaccine. And we've also got a population that's physiologically older than their biological age. So people that have had lives living in deprivation don't age in the same way as people that don't have that have more sort of comfortable, for want of a better word, lives. So physiologically, somebody in North Hammersmith and Fulham that's 60 might actually be in their 70s. That's a recognised effect, and so it's somewhere between 15 and 20 years actually. Physiologically. So we've had to throw all of that into the mix, and so we actually dropped our cohorts quite early in order to be able to use up our vaccine and meet the needs of our population. And that's created a disparity in terms of age, when you just look at age by itself, between North Hammersmith and Fulham and South Hammersmith and Fulham, where they had an older and sort of physiologically younger population base. But that's now starting to level out. And so what we're seeing is actually if you're over 70, anywhere in the borough you can get your jab. Doesn't matter where you're based. Some places have dipped down into people over 65. Others are still sitting over 70. The bottom line is that if you're over 70, anywhere at all you've got to do is phone your GP and you'll be able to get yourself jabbed. But from our patch in North Hammersmith and Fulham, we're definitely dipping down into people over 65, and to some extent people with long-term conditions that are even younger for certain long-term conditions. Does that? I'm sorry, it's a bit of a complex answer. Does that answer it?
That answer, T.
Yes, thank you. Thank you very much.
Good. Okay. It seems to me, I mean, a lot of people I know who live in Hammersmith and Fulham seem to have got their jabs actually more quickly than other boroughs, to be truthful. I don't live in Hammersmith and Fulham, but it seems to be the case here. Right, we have no more questions on chat, so open it up to anybody who wants to ask something now.
Yeah, I have more questions that we already had previously, and I think there was an answer. Can you talk more about vaccine and pregnant ladies and children?
Oh, sure. Yeah. So the vaccines, so the vaccines are licensed for use in adults. So the Oxford vaccine AstraZeneca is over the age of 18, and Pfizer is over the age of 16. So we can't give it to children. The children don't tend to get, on the whole, they don't tend to get seriously unwell with COVID. There's a whole different question here about the role of children as vectors for the disease, but in terms of ending up becoming really, really sick, they don't tend to get really unwell with it. But the vaccines simply aren't licensed for children, so they're not eligible. And unless that changes and the regulations change, then we can't give them. Pregnancy, there's no evidence. No one does studies on pregnant women injecting them with or giving them drugs to see if it causes harm to babies. No one ever. It never happens, and so it's an unknown. There's no evidence to suggest that any vaccinations cause harm in pregnancy. So this then turns into a case of balancing risk with women that are pregnant. If a woman isn't pregnant, the general advice is for them to try not to get pregnant within 2 months of having had the vaccine. If a woman's already pregnant, then it's a risk judgment in terms of their health condition, how unwell they would become if they were to get COVID, how exposed they're likely to be to getting COVID due to occupational reasons, for example. The balance it's a balanced judgment on the individual case. So there are certainly women that are pregnant who've had the jab, but like I say, it's an unknown as to theoretically it shouldn't cause problems to the baby, but there's no evidence on it. There's no studies on it. Does that answer it?
Yeah.
Okay.
Zainab, you've got your hand up, and then I'll go to T again. So Zainab.
Thank you, Doctor, for your information and for your talk about the vaccination, COVID-19. You spoke about the reaction with the antibiotic, and you said that there is no evidence about if someone got a reaction with the antibiotics. That's mean there is nothing, it will not happen anything. What about the chemo? If someone got sensitivity or reaction from the chemo, is there any evidence with the reaction with it, or?
No. So in terms of allergies, so when people have allergies, they produce antibodies, a particular kind of antibody that triggers a branch of the immune system to become really, really active, and you get this histamine released as a chemical, and that's what drives anaphylaxis, which is the only allergy we worry about is the really, really serious life-threatening ones with these. And so people can do that to anything. It could be to chemo drugs or to antibiotics or to other medicines or to skincare products or to peanuts or anything at all. But the vaccine doesn't contain those products. So the vaccine contains an active ingredient and water and things that keep it stable. And so if someone's taking chemo, there's absolutely no reason why they wouldn't be able to have the vaccine from an allergy point of view. The issue really is around their ability to make antibodies. So people that have their immune system suppressed might not get as much benefit from the vaccination. So the purpose of the vaccination is to help them produce antibodies, and so the body then has the capacity to fight off infections. So if they're taking medicine that suppresses their immune system, they might not be able to make those antibodies as well as somebody that's not on immune suppressant medicine. So the vaccine might not work quite as well. That's not to say they shouldn't have it, but they should just certainly discuss it with their specialist. I've come across some people where they've been advised by their specialist to stop some of their medicines ahead of having the vaccine, and actually they've prioritized the vaccine above treatment of their condition, but obviously that has to happen on a case basis.
Is it another question? Is it muscles? It will inject in the muscles or in the vein or?
No, so the vaccine gets delivered into a muscle, so it's usually the shoulder muscle. So it's just the same as any other vaccine. So no, it doesn't go into a vein. It goes into the muscle, and the medicine sits inside the muscle, and the body then comes and produces the reaction locally, and so that's why people often have a bit of a sore arm afterwards. I know there's people on the call that have been vaccinated. Hands up if you had a sore arm. I did. Yeah, there we go. That's why you get a bit of a sore arm for a couple of days.
I did.
Did you? Yeah. It lasts a day or two, a bit of a sore arm, but then it fades away. Does that answer?
Yeah. Thank you
All
very
right, Zainab, thanks for that
you.
question. T, do you want to ask your question now? About,
Hello. Could you tell me, when it first came round, blood pressure was, they said like half the people that passed away had blood pressure. Can you tell me what category that is now? Is that have they worked out that it isn't that bad or?
So just make sure I understand. So you're in the people that died from COVID had blood pressure problems. Is that?
Yeah, that's what they said initially.
Okay, so the kind of things which can make somebody more at risk of serious illness with COVID, so of COVID being much more severe, definitely include long-term health conditions. So it's the number one factor is age. Above everything else, the older somebody is, the more likely that they are to have a much more severe illness with if they get COVID. And then you start to get into the comorbidities, and there's a gradient to this, and so it's a respiratory virus, and so people with long-term lung problems, so severe COPD, severe asthma, definitely much more at risk of becoming really, really unwell. Heart failure is another one, so if the heart's not pumping as well, the lungs can get congested, and that can cause problems. Diabetes, things that suppress the immune system, so cancer treatment, which we've been talking about. Blood pressure is on the list, but it's blood pressure where there's complications. So long-term poor control of blood pressure can mean that the heart doesn't pump quite as well, for example. So just having blood pressure by itself doesn't necessarily mean that you're going to be massively more at risk, especially if the blood pressure is well controlled.
Thank you for clearing that up, my love.
That's okay.
I've always wondered about it, never heard nothing. Thank you.
That's okay.
Thank you.
That's
Doctor.
okay. It gets really tricky because, and it's going to get trickier now going forwards, because I mentioned the categories. It goes 1 to 9, and the initial priority groups 1 to 4. We're moving now into number 5, which is over 65, and then number 6. Now, number 6 is anyone aged 16 to 64 who has a long-term health problem. Now, quite clearly, when you're looking at the records and the GPs are calling people saying, "Do you want the vaccine?" that it's not going to be coded on the record to say that someone's got severe hypertension with complications. It's going to be just say someone's got blood pressure. That's all.
Yeah.
And so people with blood pressure are probably going to get an invitation within the next, probably within the next couple of weeks, actually, to say, oh, come and get your jab. So that's not to say that you need to be super worried by it. It just means that it's just the way that the coding happens at this level.
Thank you for clearing that up, Doctor. Appreciate that immensely. Thank you.
I'm going to go to Rahman in a minute. Does that mean that then a judgment is made? I mean, because some people who, for instance, I know a couple of people who've had the same kind of cancer but live in different boroughs. One has been asked to shield and the other hasn't. Is that what judgment is that based?
Oh my goodness, the shielding.
Yeah.
Oh, it's okay. You're bringing back flashbacks for me from a year ago. So the shielding, I don't want to get too political, but the initial shielding advice that came through was, if you go back to I want to say March, I think it was the end of March of last year, was that it was people over 70. So age was part of it, diabetes was part of it. There were all sorts of categories, and people got letters saying you have to shield. And then literally within a fortnight, it all changed. And then suddenly age was removed. So you could be 90 and you know, without any kind of illnesses, and suddenly you weren't considered to be at risk and you weren't officially shielding. So it completely changed. And meanwhile, people had letters, and so it became immensely confusing in terms of who's shielding, who's not shielding. And that got reinforced. That confusion was worsened because suddenly letters were coming out from hospitals, practices were being, and so the guidelines were really, really difficult to navigate. So there will undoubtedly be people who have been told to shield by the government, who, when they speak to their practice, they're told actually the new criteria doesn't really say that, and vice versa. So that's probably why there's this confusion.
Complex, yeah. Okay, thank you. Rama, your question.
Hi, thanks, Helen. I'd like to say I apologize in advance for children in the background noises. Dr. Chad, I'd like to say thank you. This has been my third opportunity to get this Q&A from you. I've been in some of your other Q&A sessions. And to be honest, I have been blown away, because I was one of those people who have been told so many different things and I was too scared. And you have taken away a lot of the misconceptions that have been placed by all the negativity that's been moving around. So for that, I'd like to say thank you. The question that I have is, after the people in Hammersmith and Fulham have been given the vaccinations, has there come any report in terms of, has it reduced the number of Covert that has been, the daily number of Covert, has it reduced that? I'd like to know what the result has been since we have been giving it to the Hammersmith and Fulham resident.
Yeah, Rama, thank you so much for saying thank you. And to me, it's, you know, it's always been the sessions I've done. It's been an honour actually to have the chance to come and talk to people. So, but thank you so much. That means a massive amount to know that it's made a difference to you. That the vaccination campaign is really young, and so the numbers, the prevalence of COVID in the community is coming down. The number of admissions is falling. So COVID, when we got at the start of the new year, you know, going into from Christmas and going into the first week of the new year, I'd never seen the NHS in that kind of state. I've worked in the NHS for the best part of 30 years, and London, the whole of London was on major incident alert. The entirety of London. I mean, the disconnect between the kind of messaging that was in the press and the reality once you stepped into a hospital was, honestly, I've never seen anything like it. And so we're nowhere near that scenario anymore. So yes, there's less COVID. Is that due to the vaccination campaign? Probably not. So the vaccination campaign is targeting just a small proportion of people at the moment still. And actually it's still quite early in terms of people that have been vaccinated. I mean, from our hub, they'll be a month in, so they'll be starting to generate some immunity. But at population level, that's unlikely to be the thing that's having the impact. So that the herd immunity question is, usually you need to hit 70-80% of the population for the transmission across the population to be reduced. And so yeah, we wouldn't be anywhere close to those kind of numbers. So it may have made some difference to a few individuals, but the vaccination won't be the thing that's driving it at population level. It's going to be the lockdown that's doing that, I think. Does that answer?
Thank you. Yes, thank you.
Okay, more questions. I haven't got any more on the chat now. Just if you want to raise your hand or unmute yourself and just shout out.
Can I just ask a question, please? It's Mary, Chad. Hi.
Hi, Mary.
Firstly, I just want to say, anybody who is apprehensive in any way of receiving this vaccine should definitely not be. the management of it all at White City Hub has been absolutely amazing, especially in the beginning when you had the Pfizer vaccine and had to administer it to so many people in such a short space of time, and the actual flow and management of it all was truly amazing to see. So I wanted to thank you for that. I've forgotten my question now.
Have you really forgotten? Because if so, we'll ask, you think, Mary, and let Nushin ask hers, and then you come back, okay?
Yeah, sorry.
I'll take over for now. Chad, I wanted to ask, so I've had lots of people ask me, so Nushin, you've had the first jab, so does that mean, you know, that when you have the second jab, you won't get the coronavirus, you won't need to wear the mask, you won't need to be as careful as I am being because I have a pre-existing condition, for example?
No, I know this is another. Sorry, I should have said that at the start. That's another common question, and it's one that some people have. It's an anxiety people have had to think. Well, actually, why would I have the jab if I've still got to wear a mask? So the vaccine protects you. So it protects you against becoming really, really sick in the event that you get COVID. It doesn't necessarily stop you from getting COVID in the first place. So people that have been vaccinated, they can still get infected, but they won't get really, really sick if they do get infected. That's the point of it. The issue here is actually whether people will still be infectious. So if you've been vaccinated, you get COVID, can you pass it on to somebody? Because quite obviously, if actually you can't pass it on, if you've got it but you can't transmit it, well then that's the bit which is going to enable you to go out in society and you're not at risk to people even if you get it. And that's the bit that's not known. So they're doing studies on that at the moment. There's some very early evidence that suggests that you might not be infectious if you've been vaccinated and you get you get COVID, but it's still not clear. So as it stands, you still need to wear the mask. You still need to follow all the regulations, even though you've had, even if you've had 2 doses. But that's not. I wouldn't use that as the argument for not having the jab. So if you've had the jab, the idea of this is that you won't get super sick. And like I said, with the Kent vaccine, I mean, there's this misconception about it's just people that are really, really old that end up in ITU. That's not true. I think the average age of someone in ITU at the moment is about 60. And I've certainly seen people in their 30s that have needed to be intubated. So young people are getting sick with this. So that would be my message to the people that are asking you. Would be they need to make that judgment call on their own sort of well-being, really. So the purpose of this is to not get super sick if they get the virus.
Okay, Nushin.
Because I have a pre-existing medical condition, I'm being more careful anyway. So I'm just being my normal self, even though I've had dose 1.
And that's absolutely the right thing to do. Yeah, you can't relax any of the masks and the distancing.
Everyone, if they get it differently. Like, when someone gets a cold or a flu, everyone reacts differently to it.
Yeah,
that's
absolutely right. Thanks.
Thank you. Mary, have you remembered your question?
I have, yes, sorry about that. Yeah, I was just wondering about the immunity. How long after the jab does the immunity kick in?
Yeah, so you start to build immunity anything after about 10 days, 2 weeks, give or take.
Right.
And it starts building up. And so by the time you hit about a month, I mean, it varies in each person, but by the time you hit a month, you're really starting to get some immunity. And so this is the argument, like I said before, about the Pfizer vaccine. Yeah. This is where they did those studies. And so, and it's why you're getting some variance of opinion. So some people were saying after 3 to 4 weeks before the second dose, you had 50% immunity with Pfizer. But then after the second dose, within a week after it, you had 95%. And so the argument from the scientists is that wasn't due to the second dose. That was the first dose, and it was just building up. And so after a month, you will definitely be getting decent immunity coming through from your jab, whether it was the Oxford one or the Pfizer one.
Fantastic, thank you.
And Mary, I just wanted to sort of say thank you to you as well in terms of the. I mean, this has been, from our point of view, logistically, and it's the same across every single PCN hub. We get sometimes 24 hours notice for delivery of vaccines. It's crazy, honestly, and we don't get to choose what gets sent to us. We don't get to choose how much gets sent to us. We're just told, tomorrow we're sending you this, and we've just got, okay, right. And so when we had our first batch, we had to do it alongside the food distribution, didn't we?
I know.
Do you remember? And so everyone was so flexible. We suddenly had to move the tables around in order to maintain the flow. We had to change the booking system, everything, in order to do it. And so, I can't imagine us having been able to do this without you being and White City Community Centre being so accommodating.
Oh,
So
you're more than welcome, Chad. Yeah.
Okay, can we hang on, Zainab, for 1 second. Carmela.
Yeah, hi, Chad. Thank you so much for doing this. We really appreciate it. I just want to ask you, if you do happen to catch COVID, how long do you have to wait before you can get the vaccine?
Yeah, this is a difficult one. The most people are saying a month. If you look at the actual guidance that's come from the government around it, they leave it ambiguous. Now, the reason why I'm saying this is that if you had COVID, you didn't get tested, but you just had some symptoms and it was never confirmed with a test, it would be 2 weeks. If you had exactly the same symptoms, but you went and got a test, then people are saying 4 weeks. But the government is saying, actually, we're leaving it ambiguous. They haven't stipulated a timing on it. So there's two reasons for delaying. The first one is so that when you come to a vaccine centre, you're not going to give anyone else COVID. And so for that, the minimum time frame would be 2 weeks. You'd have to give that time before you start to come out and circulate anyway. And then the second one is to not get any confusion in regard to vaccine side effects. So there's some argument about efficacy of the vaccine, but actually it's predominantly around the side effects from it. So it's a little bit unclear. Most places are saying a month, but actually after 2 weeks you probably won't have any real problems. Does that
okay? Yeah, thank you for that. I wasn't sure whether it was 28 days or 2 months.
Yeah.
And the other thing as well, just coming off the back of that, if you do happen to catch the virus, how long do you have the antibodies in your system? Is there any kind of research on that? Is it 6 months, a couple of weeks, a month, or maybe people don't know?
Yeah, it's going to vary. So all of us will produce antibodies at different rates and to different degrees. And so the amount of immunity that you'll have after having caught COVID without having been vaccinated is going to be different for each individual. And no one really knows how long that immunity lasts. But the general consensus, and this isn't just from people that made the vaccines, this is scientific across internationally, is that you won't produce as much immunity from having caught it naturally as you would do from a vaccination. So the vaccination gives you a better antibody response than having caught the infection. And the second dose for the vaccines extends the duration of that antibody response. So that it's almost like a booster.
Okay, thank you.
Okay, I know time's moving on. Zainab, and then Claire wants to ask another one, I think. Zainab?
Thank you very much. Another question for the people who are vaccinated already. Can they travel abroad, or they will have a certificate? Because some of the countries, they give them certificate that they are vaccinated already. And do they have to do the viral test or not before they travel?
Yeah, so so the travel is, it's a big issue, isn't it? What's going to happen with travel? I think every country is going to end up doing its own regulations in terms of stipulating whether you have to have a test or whether you have to have any paperwork to say you've been vaccinated. And you can just see what's going to happen with this. It's going to end up with, dependent on each country, there'll be different requests. So the short answer to that is that it's not clear. What it depends on where you're going to go to, but it's not clear as to what the regulations will be in terms of travel passports and whether you've had a COVID jab, or I suspect it will depend more on the COVID test prior to travel than the actual vaccination, but no one really knows. I think what I'd say is, if you're worried, or if people are worried about whether they should have a vaccine, I wouldn't base it on the ability to travel, because those regulations will change. They'll change constantly, whereas actually the decision to get jabbed is actually about protecting yourself against getting really, really sick. But yeah, the travel regulations, it's up in the air, isn't it? No one knows really at the moment as to what's going to happen with that.
Okay, Zainab. Claire, do you want to ask your question now?
Yes, please. What's the difference between the two vaccines, please?
Yeah. So do you mean like in terms of what they are or their effectiveness?
Both, please.
Yeah. So you've got the Pfizer vaccine is what's called an mRNA vaccine, and so it's a component, effectively a bit like a protein, and so it's not a virus. It's just like a part of a virus, and so it gets into the body. It degrades within about 3 days, and it just stimulates the body to make antibodies against the COVID virus. The evidence is that you're looking at 95% protection with Pfizer against the variant it was tested against. The challenge with Pfizer is it's more operational. So like I said, you've got a really short shelf life. So when it comes out of the deep freeze, you just got to get it delivered. If you haven't delivered it by the end of that shelf life, you have to throw it away. And so logistically, it's got to be delivered from vaccine hubs. You can't, as a long-term campaign, you can't do it from pharmacies or GP practices in the same way as you can do with a flu jab, for example. The AstraZeneca vaccine is an inactivated virus, so it's not like a bit of protein. It's a kind of virus that causes colds. That's inactive. It's not live. It can't cause symptoms, but it's more like the other sort of vaccines that normally get produced. And so you produce antibodies in the same way, but it's slightly different in terms of its composition. The evidence is a bit mixed on AstraZeneca, but it's somewhere between 50 and 80% in terms of its effectiveness. But they're arguing that it produces those kind of antibodies for a longer duration. And so the additional benefits of one over the other, is not just about the effectiveness. They're both effective, but I wouldn't get too fixed on the numbers. 90-95% versus 70-80% for the AstraZeneca. It's a more complex argument in terms of the how long it lasts for, the transmissibility, and also the AstraZeneca. It doesn't have all those sort of deep freezer, -70 kind of issues to it. So going forwards, I suspect what will happen is that will become the vaccine that people have. We're likely to need to have boosters, and with that vaccine, you can just store it in a fridge. You could deliver it from a GP practice in the same way as people get flu jabs. So I would expect for next winter, I'm sure the next winter we'll all have to have repeat jabs. I suspect that's the one that people are going to have. We don't get the choice, so we'll just get sent. Mary will know. We just get sent batches of vaccine, and when you've got Pfizer sitting with you in the fridge, you just got to give the Pfizer. So if we've got Pfizer, it's Pfizer. If we've got AstraZeneca, it's AstraZeneca, and we don't get, unfortunately, to say which one. We can't choose when it arrives. We can't choose what comes to us. Does that help?
Yes, thank you.
I have one question.
Can I ask one question?
Yes, of course. Go ahead.
Hello.
Hello.
Hello. Can I ask a question? Is the affecting all the population like Asian and Black people and all? The vaccine, is it effective to everyone? It gives the same immunity to the people? And what percentage? I mean, is there a center at Parson Green for vaccination?
Yes. Yep. So there's two questions in that. So the where are the centres located, and also the effectiveness by ethnicity. So there's no evidence to say that it's any different across different ethnicities in terms of the vaccination, and so there's no reason why any particular ethnicity shouldn't be having the vaccine. Everyone has to follow the same, and that applies to both the Pfizer and the AstraZeneca. And everyone has to follow the same regulations after it anyway, like we've been talking about. You still have to wear the mask and distance and so forth afterwards. There is a difference in uptake, and it seems to be that it's Muslim communities and Afro-Caribbean communities nationally that have got the lowest uptake for vaccine. And so I think that this for me, I think, is an issue of trust, and there's all sorts of context to all of this as well. Like I said at the start, it's amplified all of those tensions. COVID has amplified all those tensions that were there in society, that have been in society for decades. And unsurprisingly, that's all manifesting within the vaccination campaign. But scientifically, absolutely not a problem. It doesn't matter ethnically in terms of having the jab. We've got our centre set up in the community centre. In the centre of H&F, it's being delivered from Richford Gate as the GP practice, and in South Fulham, it's being delivered from Parsons Green. So those are the three hubs. In terms of accessing the vaccine, all that people need to do, it's really easy. All they need to do is just phone their GP. Just call the GP. I really like to have the vaccine, please. Can I have it? How do I get an appointment? Couldn't be easier. People are going to be getting national booking letters. I know that they're getting sent out from the government, and they've got all sorts of stuff saying, please click on this link, book online. You go through a whole process. I had a 93-year-old that lives opposite White City Community Centre who thought he had to go up to Wembley, and so there's a lot of confusion around the booking that's coming because of these letters that have been sent through. So you can go to the mass sites if you want to do that, but like I say, the easiest thing to do is just phone up your doctor. Just get people to phone the GP and say, I'd really like to get a jab, please, and they will be able to find you a slot.
Thank you so much for the information.
That's a good question. Thank you for the question, Amina.
I haven't had the vaccine yet. I'm over 70, but I haven't had the vaccine, so I was just thinking about it. Should I have it or not?
Yeah. So if Parsons Green is your local, I know that they've got vaccine at the moment, and they're doing a campaign. So all you need to do if you want to have it is just call your doctors, and they'll guarantee they'll be able to slot you in.
Thank you for that question. Nieves?
Yeah, I have one private question and two, and I think we have to stop after that because we are already after the time.
Can I ask questions?
No, we can leave it. I mean, if we can still run over a bit, then we can. Chad, are you happy to carry on for a little bit longer?
I'm going to have to go in the sort of next 5 minutes or so. But yeah.
Okay, so just ask one. If anybody's got a real question they want to ask, please.
Yeah.
Say now, and then.
Can I ask a question? I have two questions, but if you have time.
Yes, go on.
Oh, thank you, doctor. I catch up late. I just want to ask you, is there people that doesn't need to take it because of their any condition?
Okay, so medical conditions, you mean?
Yeah.
Yeah. So the only two kind of reasons for being cautious would be, so obviously pregnancy we've talked about, and then the second one would be if someone's really immunosuppressed. So in people that are on some heavy duty medicines to suppress their immune system, they should probably speak to their specialist. Not because there's an issue of safety around the jab, it's fine, but it's about whether they'll get the benefit and whether they need to actually adjust their medicines before having the jab. But medical conditions, heart failure, COPD, diabetes, blood pressure, absolutely not a problem at all. You can still have the jab.
Okay.
I think you already answered one private question I had from the chat, but the second one I had is, how about if you didn't want to take the vaccine in the first time they asked you, but you changed your mind? How can you ask again, or do you have to wait until the NHS came back to you?
Yeah, so the door never shuts. So if you changed your mind, and people are going to do that. I mean, I totally get it. COVID is scary, and then suddenly you've got all this confusion around a vaccine. There's so much misinformation. Totally, it's normal that people are that there's going to be a variation in uptake. People are going to want to have time to think about it. So yeah, the door doesn't shut on this. If you've changed your mind, it's absolutely fine. Like I said, just call your GP. The issue that we're going to have is around supply. So like I said, we don't get to control the supply. It comes to us in batches, and so we've not actually had any vaccine for a few weeks now. We've kind of eked out what we've had. So in North HNF, we've got a clinic on Friday. We'll be vaccinating, but as it stands, I don't know if we're getting when our next batch is going to come through. So it's more about getting it when you want it, as opposed to whether you'll be able to get it. So if you decided today, for example, you want to have the jab, it might be that we could fit you in this week. We could do, whereas if we don't get any vaccine next week, you'd have to wait a bit longer.
Mm-hmm.
I'm going to discuss this very quickly, which is on the chat. If volunteers are escorting local people to vaccination centres, the elderly and the vulnerable, where there's no social distancing or it's not possible, is it possible to argue that those volunteers who are taking the people should be vaccinated?
Yeah, I totally agree with you, and it's one of the things I get quite cross about, and that the way that they've categorised the frontline staff. So frontline staff come up as category 2, so really high priority. It's the same as people over 80, and the purpose of doing that was to try and maintain services. They didn't want, there was lots of staff sickness, and they wanted the NHS and social care to be able to keep running. But what they didn't do with that was think about the core economy and all the people from the community that are doing exactly like you've just described, that are crucial for communities to keep going. And so in our hub, we just absolutely said, yeah, volunteers, please come along and we'll jab you. But that's not the official line. I know that the council are very supportive of that as an approach, but that's not the official line, and I don't know if it's going to be the same in every single hub. But certainly, from the only bit I can control is what we do, and we most definitely want to be able to vaccinate people that are volunteering, because we recognise that they're frontline in the same way as everyone else.
Okay, I think we better stop there. I think.
Can I ask one question?
Okay. Hang on a sec. Yes, if it's very quick, because Dr. Chad has got to go.
Okay.
Really quick.
Okay. What about these people if they don't want to take the vaccine? What is affect them in long life, in social life?
Yeah, so it's a personal choice. If you don't want, no one's going to force anyone to have the jab.
Stand up, okay.
There's no mandate to have the vaccine. In terms of the longer term implications of not having the jab, are there going to be any regulations socially around having it or not having it, or what you can and what you can't do? That's unknown. I mean, if you look at working in healthcare, you can't work in healthcare unless you've been vaccinated against hepatitis B, for example.
Yeah.
So are they going to be at some point in the future, are they going to stipulate you have to be vaccinated against COVID to have a healthcare job? I don't know. But as it stands, there aren't any, I'm not aware of any restrictions for mobilising in society or doing things. And the jab is totally voluntary.
Okay.
Thank you.
Thank you.
Thank you to everyone for coming. Thank you for your time, everyone, in coming to this session. Thank you, Chad, in particular, because I know you're a really busy man, and that was really, really informative. Thanks very much to everyone. I hope you found it useful, and I hope this is going to be the first of several.
Thank you so much.
Okay.
Thank you, Doctor. Thank you, Helen.
Thank you all for coming.
Thank you for organising. Thank you, Chad.
Thank you so much. Thank you, Nieves.
Thank you, Chad.
Thank you.
Thank Helen.